Hey everyone, welcome back to the Tokyo Living Podcast Injury Edition. It's been a while since we've done one of these. We spent most of the last few months with our content talking about winter injuries, skiing and snowboarding injuries. I hope that if you did happen to go to the snow, that you managed to avoid being injured. And if you did find yourself in a bit of mischief, that you're recovering well. Today we're going to be talking about neck pain. Now, for those who have a particular interest in neck pain, perhaps you're experiencing some neck symptoms and you're looking at different treatment options, or you're just trying to get a bit better understanding on what's going on with your neck, then I would recommend you go back and listen to the episode that we did just before Christmas when we talked about back pain. There's a lot of differences in the way that we approach, the way that we assess, the way that we manage lower back and neck conditions. The mid back, the upper back is a little bit different. It's a slightly different beast, but there's definitely a lot more similarities between the lower back and the neck. So if you want to get a little bit deeper in terms of the content that we're going to be talking about today, I would recommend that you go back and have a listen to that episode. However, it was a very long episode, and so if you want to get a bit of more of a glimpse into the neck without having to listen to, I think it was like a 2.5 hour episode, then I'll try and condense a lot of that information and how it is relevant to the neck in today's episode. And there are also a few differences in the two areas. They're not exactly the same structurally, and they definitely have different roles within the body. And we'll go into that in a little more detail in a minute. So the neck is probably the second most common area of the body that we treat in the clinic, second to the lower back. And in terms of musculoskeletal conditions, it's second to the lower back in terms of its impact on human suffering. So it's ranked around fourth in terms of the number of years of disability associated with the condition. So it is a real problem for a lot of people, and for many people it is something that becomes chronic and it causes a lot of problems with their life for a prolonged period of time. So starting at the start, like we did with the back pain episode, we just want to conceptualize what we're talking about when we're talking about neck pain. We're essentially talking about a discomfort, an unpleasant sensation that is perceived to be coming from the neck. Now, with the lower back, there's definitely more scope for areas of the body referring to the lower back. And that's definitely the case in the neck as well, but much less so. So in general, when people are experiencing pain in the neck, if there is a structural cause of the problem, it's most likely in the neck. Luckily, we don't have too many non-musculoskeletal conditions that are going to refer pain in the neck. Luckily, these are relatively rare in the lower back, but they're even rarer in the neck. So generally, we're not too concerned about red flags. However, if someone does have neck pain that doesn't fit a typical presentation, typical mechanical inflammatory presentation, then we are always doing our due diligence in terms of imaging where necessary and try and identify any non-musculoskeletal causes of pain. As with lower back pain, we do approach acute neck pain and persistent neck pain quite differently. And even within acute neck pain associated with trauma and not associated with trauma are also two very different conditions. With lower back pain, we think of traumatic onset of lower back pain as more common than neck pain. So if I was to go and lift a heavy object and my back pain came on quite suddenly, that's an acute onset of lower back pain associated with a specific task. Or I did a very rapid twisting movement, I was playing sport and I felt a tweak in my lower back. That's an acute onset that's associated with a specific movement. Higher, and with those sort of injuries, we're not terribly concerned about structural damage. It's often a low-level strain to a disc or a joint or a muscle that will usually respond to relative rest and a graded return to function. And for those type of issues, we're not too concerned about long-term. Those tend to do well fairly long-term if they're managed in the right way. With neck pain, we have what we call an acute wry neck, which most people should experience or expect to experience maybe 2 or 3 times during their life. Will often happen either upon waking, so we'll wake up with some stiffness in the neck, or we'll wake up with a bit of stiffness, but then we might, and this is what we commonly find as a presentation, is that people will be in the shower, they'll go to pick something up, and then they'll feel an acute onset of pain. That is a very normal presentation, and that will usually get better in a week or 2. And that's not generally something to be concerned about. So if you're rushing off to the doctor, you're getting scans because you've woken up with a really bad, and these can be terribly painful, and I'm not dismissing how horrible an acute wry neck can be, but generally they're not associated with long-term damage or really any tissue damage at all. If someone is coming into the clinic with an acute wry neck, we'll do our best to try and lower pain levels. So often some manual therapy and the right type of therapeutic exercise, it can be useful in terms of settling symptoms and making that 2-week period in which someone will normally recover from an acute wry neck more comfortable. But they will usually recover within a pretty predictable time frame. And when they don't recover, then we'll talk about that in sort of the next section of this episode. What happens when something does become persistent. The traumatic origin, however, is, I guess, a little bit more serious and does require a little bit more long-term follow-up. So if someone is in a motor vehicle accident, which is where we typically see these acute onsets, or if they're playing contact sports and they receive a large high velocity or large force trauma to the head or to the neck, then that can cause a significant neck injury. Now, obviously, in these cases where there has been trauma involved, we do want to go through necessary imaging processes. So in particular, taking an x-ray and ruling out any fracture, because fractures of the neck can be very serious and can have pretty serious long-term sequelae. And then if we feel necessary, we'll refer on to an MRI as well. Once we've ruled out any major tissue damage, then we need to look at how that traumatic injury has affected that person's function, whether they have ongoing range of motion restrictions, muscle impairments, because the research shows that muscle impairments and muscle changes in muscle coordination are quite prevalent after a whiplash injury. So if someone has gone through this injury process, then we'll usually follow them up over a period of time and make sure that we're working on maintaining good function in the neck and the areas around. Often with a whiplash injury, someone might not experience pain at the time, but because of the changes in muscle coordination that are associated with the trauma of the incident, now this might be structural trauma, it might even be psychological trauma. Usually, if there's enough trauma involved to cause a whiplash injury, then often it'll be a very psychologically stressful incident for the person. And so we need to address some of those factors as well. So as with any musculoskeletal condition, there's not always a correlation between the amount of pain that someone is suffering and the degree of tissue damage. And sometimes there might not be any tissue damage. There may be an initial acute injury, but often the acute tissue damage might settle and someone is still left with prolonged pain for a myriad of different reasons. And these may be psychological in nature. So someone's beliefs, someone's sort of learned pain experience can cause an acute injury to last for much longer than the natural tissue healing time would suggest. And it's important to sort of take these factors into account. Someone might have a tissue-based injury that then becomes chronic because of other lifestyle factors such as stress levels, sleep, nutrition. All these things are considered aspects of load, and our episode on load is another injury podcast that I would recommend anyone who is watching these episodes and trying to get an understanding of how we go about addressing musculoskeletal pain. It all comes back to looking at someone's load and having an understanding of what load actually means, and the different types of loads are important. So again, I would recommend that you go back and have a listen to that episode. So when we're talking about persistent neck pain, so this is a type of pain that goes on for longer than we would expect past the normal healing time of a tissue. Then we start to approach things a little differently. Now, this might be associated with an acute or a traumatic onset of pain, and if this is the case, then there are, like we said before, things that need to be addressed. So we need to look at the muscle function. There may be deficits in coordination, in strength, in control that need to be addressed with a specific and graded rehabilitation program. There might also be psychological problems associated with the initial onset. People might have a pain that's invoked by memories, by thinking, by remembering, by talking about the onset, because obviously things like car accidents and things that tend to cause traumatic neck pain can be very emotionally traumatic as well. And so this might require a referral to a mental health practitioner. If someone has developed an acute wry neck, as we described earlier, and then they've got symptoms that last beyond the normal sort of 2, maybe up to 4 week healing time, then we've got to look and see what might be contributing to a delayed healing. Now, it might be a psychological issue. That person might be under a large degree of psychological stress, emotional stress, poor sleep. All this sort of thing feeds into delayed recovery times. And there might be some biomechanical issues that have been contributing to this as well, and we'll sort of talk about those in a minute. If someone is experiencing a persistent neck pain that's not associated with an acute onset, that they've had this gradual onset of pain that's now just there and won't go away, then we need to look at the different factors that are contributing to this. This is where we look at our load diagram and see which aspects of the load are most likely to be contributing to this person's pain. Again, if you haven't watched that load video, then go back and have a look at that, because that sort of details how we'd approach all of our musculoskeletal pain conditions. So if we're looking at the direct tissue-specific load, we're looking at possible structures that might be involved, and also movements, aggravating factors, and also directions where the people might be experiencing their pain. Like with lower back pain, neck pain can be very direction specific. So some people might have pain sort of moving backwards, or moving, if they've got left-sided pain, moving towards that left side might be really stuck, but movement in the opposite direction is generally okay. We will look at the type of movements that person, or the type of activities, postures that person is in throughout the day, and see if there's ways in which we can modify those movements. So if someone is experiencing pain with what we call flexion, so looking down, then they might be spending a lot of time working on a laptop or working on a device where they're spending a lot of time in a flex position. And if we know that flexion causes their pain, then that's an indication to try and modify the movement patterns and the amount of time or volume or intensity of those activities to try and decrease symptoms. And this is where ergonomics may come into play. So we may need to have change their working environment, or even just use cueing and coaching techniques to get people out of those postures or those movements. Posture is often demonized and talked about as a cause of pain in terms of having quote unquote bad posture. Having a slumped or slouched posture per se, there's very mixed evidence regarding whether that is causative of neck pain or not. And for every study you find that says that it is causative, there's another one that proves that it's not. However, if we look at someone's presentation and it's clearly associated with certain postures, then there's definitely cause for modification of those postures. If someone's neck pain is associated with high level activities, then we may need to modify these activities in the short term and then build back up over time. So if someone is, it might be either a sport that involves direct contact or direct trauma to the neck or the head region, or it might be sports such as resistance training, where you're not necessarily applying direct pressure to the neck, or most people tend not to with their resistance training, but you might be doing heavy upper body exercises, or even so deadlifts or squats where the neck is involved indirectly. We may need to have a specific graded return to these activities. For activities that involve direct contact to the neck, let's say combat sports, contact sports, we may need to start with exercises, resistance training exercises in the direction that they might be absorbing force in their sport, and then gradually increasing the velocity and the force with which we're performing these exercises, and then building back up to their sport. The role of manual therapy in both acute onset or persistent pain. Manual therapy in the case of, say, an acute right neck can be very effective in decreasing the severity of the symptoms during that normal healing time, and then sometimes we can speed up that healing time. In the case of persistent pain, it's very rare that manual therapy will be useful as a standalone intervention. So some people might respond well to, I guess, semi-regular, whether it be sort of massage, manipulation, mobilization, needling, acupuncture, interventions like this to almost as sort of maintenance work going forward. And I have no objection to that. And I do have clients that respond well to that type of treatment. But in general, we want that to be combined with more of an active intervention. As with neck pain of traumatic onset, there may be muscle deficits involved in persistent pain. So we may have a decrease in the endurance, the strength, the control, the coordination of both our deeper neck muscles, which are often responsible for having the ability to get into more of a sort of retracted position, which in general is less stressful for the structures of the neck. Now, that's not to say that having a forward head posture is necessarily injurious, but we want to have the capacity to be able to move our head in as many sort of different directions as possible. And when our muscle function and that deep muscle function is impaired, we lose variability in our movement capacities, and that can lead to increased stress on certain areas of the neck. We might also have deficits in terms of our outer muscles, our bigger muscles around the neck, and these need to be retrained with a specific exercise program. I think oftentimes we tend to not apply the same degree of thoroughness to our rehab programs for a neck as we would for, let's say, a knee injury or an ankle sprain. And so in some ways it's unsurprising that neck pain is often recurrent. So even though we may be asymptomatic after we recover from a neck injury, and we might be able to go back to the activities that we were doing before, in order to decrease the likelihood of recurrence of the injury, it is worth trying to push the outcomes of a rehab program to a slightly higher level. When we're looking at our biomechanics, so the biomechanics of the neck, in some ways similar to the lower back, in that the upper back is important. In order for us to have the large amount of movement we need of the neck, then we also need some contribution from the upper back. If the upper back is locked in one position, it makes our neck movements very difficult. So we need to have sufficient range of motion through the upper back, and this is something that we'll assess in a neck assessment and address with some mobility interventions if necessary. Some other areas that might be relevant in the shoulder blades. So the shoulder blades often get blamed for a lot of problems in the shoulder and the neck. It's not necessarily that if someone has asymmetrical shoulder movement that's causing their neck pain, but if we can modify someone's shoulder blade movement and then have them repeat a task that might be painful before, and we get an improvement in symptoms, then for me that's justification that an element of shoulder blade rehabilitation, or even just sort of modification of movement in the shoulder blade might be necessary for them to decrease their symptoms and improve their pain. With any musculoskeletal condition, there's always a balance of load that's shared throughout the limb. So if we're talking about an upper limb condition, if we're talking about the neck, then what's going on anywhere from the fingertips through to the shoulder might be impacting the neck. So if someone's not handling load well through the periphery, then that may result in increased tone in the neck muscles, and that might contribute to someone's pain. So we look at the type of activities that is causing someone their neck pain, and then see if there are some deficits in other areas of the limb that might be causing increased load to be placed on the neck. If someone's reporting pain at night, maybe difficulty sleeping, we need to sort of look at sleeping posture, because obviously the position of the head is relevant when we're in bed. If someone is experiencing pain with movement towards a direction and let's say they sleep on that side, we need to look at maybe the pillow height. If someone is using a relatively thin pillow and that puts their head in a position that's closer to the direction of pain, and it might be comfortable for them normally, but because they have this sensitivity in that direction at the present time, we may need to, say, use an extra pillow to try and get them in a little bit bit more neutral position while they sleep and decrease their sensitivity. Now, if someone is experiencing neck pain that maybe started with an acute wry neck and is not improving past the sort of typical time frame that we'd expect, maybe they're 4 weeks on and they're still getting this wry neck, or the other presentation is if someone is getting a wry neck maybe every 3 or 6 months. As I said before, a wry neck is something that most of us can expect to experience maybe 2 or 3 times during our life. If we're getting it more frequently, then we need to assess what's going on, and that might be anything in that sort of load paradigm. So it might be increased stress, decreased sleep, it might be some biomechanical factors that might not necessarily have caused the neck pain, but are not creating an optimal environment for healing. And so we basically just go through our assessment, assessing the different areas of load and seeing which ones are most relevant and applying specific interventions to those. Some specific biomechanics factors that are a little bit more relevant to the neck are the integration between sort of the eyes, the ears, the head, and then the neck in that sort of whole upper region. Obviously, the function of the neck and the back are quite different. The back needs to carry the weight of the body and obviously perform a multitude of different movement patterns while doing that, whereas the neck has to support the weight of the head, which is still a heavy object, but the range of motion requirements are much greater. We also need to integrate the movement of the head and the neck with the movement of the eyes. One of the reasons that we require such range of motion, such great range of motion through the neck, is that often we're moving our head to place our eyes in a position which we can utilize our vision. And so we need to consider that when we're assessing it and looking at what might be causing someone's neck pain. If someone isn't tolerating load well through their eyes, then often the muscles of the neck will express increased tone because they'll be trying to compensate for that lack of load tolerance, and they'll be taking on more load and therefore contributing to sensitivity in the area. A lot of people will associate decreased eye capacity just with the ability to read at a distance or read up close, but there are different aspects of vision that need to be assessed as well. So the ability of the eyes to coordinate and focus on a certain subject, and these are things that we assess within our physiotherapy assessment. We also need to consider what we call the vestibular system. So these are the organs in our head and in our ears that give us information about where the head is in space. And if there are issues within our vestibular system, then again, the neck muscles may compensate for these. So when we're going through an assessment of someone with neck pain, we will do visual assessments and we'll do vestibular assessments, and we'll see how these are integrating with the neck and how this may be contributing to someone's pain. And this can work in the opposite direction as well. So if someone has, let's say, neck muscle dysfunction, because the muscles of the neck contain what we call muscle spindles, which basically sensors that give our brain information about the head's position in space. And we know that the deeper muscles of the neck actually contain more of these muscle spindles than anywhere else in the body. When we have impaired muscle function, this impairs what we call the proprioception of the body, and this in turn can influence the way that the brain is perceiving the position of the head. So if our muscles are giving the brain information that is different from what it's getting from the vestibular system, then it can become a little confused, and that's when we can start to experience symptoms of dizziness and sort of nausea and these type of vestibular symptoms. So it's important that we do assess all these symptoms in conjunction, and we have very specific assessments that we use to do that. So part of our neck assessment may include specific tests to look at the accuracy of our joint position sense, as well as balance tests to see how The other area of relevance that has close proximity to this region is the jaw. So there's people that might report pain or even sort of clicking or cracking in this area, and a common diagnosis for this type of presentation is what we call TMD, or temporomandibular dysfunction. So this is where there's an issue with the temporomandibular joint, which is essentially where the jaw, the chin attaches to the skull. Now sometimes this might be a local problem. Sometimes it might be caused by the neck. And so often sort of issues with the neck muscles and joints may be causing some dysfunction in the jaw, and vice versa. So someone might not necessarily report jaw pain, but they may have some asymmetry or a lack of capacity through the jaw, some asymmetrical movement that might be then causing their neck muscles to be functioning in a suboptimal way. So that's another area. If someone is presenting with neck pain, and particularly pain in the upper part of the neck, we'll always assess the jaw and trying to establish whether or not this is a contributing factor. Now, although we don't need to be particularly specific in terms of structural diagnosis for neck pain, it's often useful if we sort of separate the neck into sort of lower and upper compartments, and these will present quite differently. I mean, generally, pain in the upper part of the neck might be associated with some sort of sensitivity in structures there, and pain in the lower part attributed to structural issues there. And the referral patterns might be different as well. So if someone is experiencing headaches associated with their neck pain, that might be more related to the upper part of the neck, whereas if someone is experiencing perhaps some shoulder symptoms, even pain down into the arm, that's more likely to be associated with lower cervical spine issues. Now, there might be the case where someone is experiencing pain in the lower part of the neck, but it might be due to, say, upper neck restrictions, and vice versa. In comparison to the lower back, because of the smaller size of the neck, and also the larger amount of range of motion at the different segments of the neck, we can be a little bit more specific with where we sense movement occurring, both when we're looking at someone performing active movement, or if we're actually pushing on the neck and trying to establish how different parts of the neck move. Now, this is something that's still sort of debated in terms of how much movement we can actually feel when we're palpating a spine. But for me, I have a lot more trust in my ability to feel for movement quality, movement restrictions in the neck compared to the lower back. And for me as a clinician, it has a stronger influence on how I might utilize manual therapy interventions, and also the way that I might structure an exercise program. Now, someone might also have beliefs around their neck pain. So if they have had an acute wry neck and for whatever reason they've gone down the path of having imaging, or they've seen a practitioner who's told them that they've had some major structural damage to some part of their neck, then those beliefs might be influencing the persistent nature of their pain. So that's why it's important, if someone does have an acute onset of neck pain, especially with an acute wry neck, which, as we've established earlier, is relatively benign in terms of its structural consequences, we do assess it properly and make sure that we provide reassurance and education about the nature of the condition, because unfortunately incorrect beliefs around pain can influence the chronicity of a condition. Now, when it comes to imaging, like with the lower back, it's important that we use imaging wisely. If someone has suffered a traumatic onset of neck pain, we do need to have them x-rayed, and in some cases we need to proceed with MRI to establish whether there is a structural cause or significant structural cause of pain that might necessitate different management. They may need a certain period of immobilization. They may even require surgery, or for some people it might just be a different schedule of return to activity. However, for non-traumatic neck pain, and if there are no signs of sort of red flags, if it's presenting like a normal mechanical or inflammatory neck condition, and we don't believe that there's any sinister pathology involved, then imaging is something that we really want to avoid. Like with the lower back, if we have pictures there that show us these, disc pathology, disc bulges, disc herniations, which are quite normal in people that have never had neck pain in their lives, then again, that starts to build that fear element, which can then contribute to increased pain or more persistent pain. The times where things like disc herniations and bulges might be relevant is if we're experiencing arm pain that is associated with more what we call frank negative neurological symptoms. So things such as numbness and weakness. If you're experiencing just sort of tingling and a bit of pain in the arm, that might be more related to sensitivity, so inflammation around a nerve, or just referred pain from the neck. Whereas if you're experiencing parts of your arm that are actually numb, that when you touch them, they don't, you feel less sensation than you do on the other side, or if you're having coordination issues with the hand, or if you've got a very noticeable, very objectively measured weakness in the arm, then that might be a sign that you're actually experiencing some compression around the neck and around the nerves that exit from the neck. And in those cases, the imaging findings of reduced space around a nerve might be relevant. And for those cases, we might need to apply a different type of treatment modality and may need, in some cases, a referral to an orthopedic surgeon. The last thing that we should mention, and this is something we discussed in the back pain episode, is what happens if our pain doesn't resolve. How do we go about living with neck pain? And this is something that some people have to deal with. The majority of people will get to a stage where their neck pain doesn't impact on their daily function or is completely resolved, so they don't experience pain. But there are a subset of people that will have ongoing symptoms that, for whatever reason, and there's so many different reasons that this might be the case, that they have ongoing symptoms. I think for those people, building in some coping strategies, making sure that other areas of their health are optimized, other areas of their lifestyle are optimized, and that they have really good social support. Education is key, and making someone aware that even though they're in pain, they're experiencing discomfort, that's not necessarily reflective of the health of their tissues, and that it's not only safe to continue moving and continue performing activity, but it's really important for both psychological and physiological reasons that they continue to do so. So that brings us to the end of this episode. I hope that you've enjoyed and found some of this content interesting. And like I said, if you do want to delve deeper into some of the concepts that we discussed, then I would recommend that you have a look at our back pain episode, which covers a lot of the similar concepts, but in a lot more detail. As always, guys, thanks very much for watching. And if you do have areas of the body, injuries, concepts that you would like us to talk about, then please let us know. Thanks for watching, and we'll see you on the next episode.